All right, everybody, welcome to DaVinci Academy's live neuroanatomy review. Thanks for coming out. We appreciate it. We're just going to get you started here with just a brief introduction about us. So first, what is DaVinci Academy? dviacademy.com, that's our website. So first, we're a company I started in medical school with some of my colleagues that is based on my tutoring techniques of using just really boiling things down to the concepts of what you need to know and then using as many clinical examples as possible and really, bringing these to where you can apply them to, clinical scenarios that are frequently tested on your school exams and then on also the USMLE or any board exam you may be taking. And right now we have a book for anatomy. It's 310 pages with over 200 diagrams and a lot of radiology images. I'm an incoming radiology resident, so I certainly made sure to have radiology education be an important part of that. Biochemistry is a 139-page book, and we cover biochemistry, metabolism, molecular bio, genetics, all those topics for you. And then we have DaVinci Cases, which some of you may be familiar with. Those of you who follow us on Instagram and YouTube, it's a free weekly clinical cases video series on YouTube. We're going to put one out later today. We put one out every Wednesday, and these are just to be good examples of, again, to that our philosophy of applying these to clinical scenarios. And these are typically clinical cases or clinical scenarios that are frequently tested. So these are the covers. I've got the link in the description if you want to visit our website and see any of our products, and then also if you want to see any of our books on Amazon. We have our books available on Amazon as well, so you can see the links in the description. All right, so now that we've gone through kind of the background on the company and who we are, the session plan today is we're going to cover the core concepts for the following topics. So neuroanatomy it's too broad of a topic to cover in one session, so I'm going to focus on these four because these tend to show up a lot on exams. So stroke, visual field defects, neurotrauma, and hydrocephalus. And then after we go through kind of the core concepts for each of these, we'll have a nice clinical case for each of them at the end. Feel free to ask questions as we go through. The best way to do that is by putting it in as a comment, and I can see your comments coming up, and I'll be sure to respond and hopefully answer them for you. Again, thanks for joining. We're happy to have you guys here today. So the first thing, stroke. So by basic definition, it's a lack of blood flow to brain tissue resulting in cell death. Now, there's two types of stroke. You got to remember this. There's ischemic and hemorrhagic. Ischemic is about 80%, and that's what you typically think of when you think of a stroke. And so that's, someone coming in with a blockage. It's analogous to a heart attack or a blockage of a coronary vessel in the heart, and it causes ischemia within the brain tissue. Then you have hemorrhagic, which is where you have bleeding in the brain. And so that's why one of the first things you do with someone with stroke symptoms sorry about that. One of the first things you do with stroke symptoms is you get a CT scan. So if we come over here, this is actually evidence of an older stroke here. You can see it here with this kind of darker gray in the CT scan. And then here, this is an example of an ischemic stroke, which is this white area here in the center right here. So for an ischemic, this is an occlusion of a blood vessel supplying brain tissue. Causes of this obviously are atherosclerotic plaque, and then embolism. So this is one that tests like to use because it's something you maybe not would think of initially. So someone who's on atrial fibrillation, remember that spazzing of the atria, and so you can have blood clot formation within the atria themselves. And the problem is if someone's not on a blood thinner like warfarin, then they can start shooting clots up into the brain, and that can cause a stroke. Patent foraminovalia is another one that likes to get tested a lot. So that would be someone, say they have a deep vein thrombosis in their in their leg. It can travel up, go through the heart, and then shunt across into the left atrium, and then out through the left ventricle into the brain and the cerebral circulation. So that's another way you can get a stroke. And then you can have a carotid artery dissection as well. And so then a clot can form and then travel up directly because the carotid artery, eventually breaks into the ACA and the MCA. So you can have a clot form in there and go up there. Risk factors for ischemic stroke are hypertension, smoking, obesity, high cholesterol, diabetes, AFib, and then previous TIA or trans-ischemic. And so for a TIA, that's when symptoms resolve within 24 hours versus a stroke is more long-lasting or permanent. You have a hemorrhagic stroke. This is bleeding from an aneurysm or a blood vessel. And hemorrhagic, we said ischemic was 80%. This represents about 20%. And then causes would be a hypertensive bleed. So someone has a long history of hypertension. This is also why it's dangerous if people don't take their hypertension medications. Ruptured cerebral aneurysm, and then trauma. Risk factors for this as well: hypertension, smoking, family history of these. So there's some diseases like Ehlers-Danlos that have aneurysms, or polycystic kidney disease, alcoholism, and then cocaine use especially. So here what we have is you have the central sulcus, which is here. And so you have the precentral gyrus, which is here. So that's where motor is. And then you have the postcentral. And that's where somatosensory is processed within the brain. And so the reason this is important is for strokes, which you want to look at is here's the homunculus. So this is a coronal view. So it's like we're taking slices looking at the face. And so if you look, this is the medial aspect, this is the lateral aspect of the cerebral hemisphere. The more medial aspect, as you can see, is more so the lower extremity. And then as you go out more laterally here, then you get the upper extremity with the hand, and then you get the face out here. And you'll see why this is important in a second. So first, before we talk about the distribution of the arteries, let's just talk a little bit about the anatomy. So you have right here the internal carotid artery. And you can also see that here. Here's the internal carotid artery here. And so the internal carotid artery, if we have ICA here, it comes up here and it splits into the MCA and then the ACA. And we'll show that here. So here it's coming in like this, and it's splitting into the MCA, which is going out here more laterally, and then you have the ACA, which is coming in here more medially, as you see that. And so one thing we'll point out here is that there's some anastomosis. This is the circle of Willis. So you have the anterior communicating artery here, which forms between the two anterior cerebral arteries, because as the ACA comes in here like this, or as we show here, and then it kind of comes up like this, it tends to shoot more forward like this, and so you have a bridging. And then this is a nice sagittal view of the ACA here, where you can see it kind of has this, where it sprays out like this and covers that whole medial aspect like I was showing you on the previous slide. And so then out here, you have, in the posterior circulation, you have the vertebral arteries, which come up through that transverse foramen and the cervical vertebrae. So you have those coming in like this. So you have the vertebral arteries like this, vertebral artery here, vertebral artery here. And so they come in and they merge at the basilar artery, which is this guy here, which travels up the ventral surface of the brainstem. So you have the basilar artery there. And then the basilar artery comes up here, and it shoots off a bunch of branches to the brainstem. And then here, it comes into the PCA, so the left and right PCA. And so these come out here, and they supply the posterior aspect of the hemisphere. And then you have here the posterior communicating artery, which help form those last legs of the circle of Willis, which bridge the MCA and the PCA together. Now, the important thing about the communicating arteries is these are actually common areas for aneurysm formation. And so that's something to keep in mind, either an aneurysm at the anterior communicating or aneurysms at the posterior communicating. And then obviously you can have a stroke in any of these. So the distribution, these are important to remember. So if we look at the sagittal here, you have, this is for, in orange here is the MCA. And then on an axial here as well, you can see where it's this more lateral portion like this. And then the more medial portion here, which makes sense because you remember the MCA is kind of coming out like this. And then the ACA is coming in like this. And so that makes sense that the MCA and the ACA are going to cover these distributions respectively. And so this is a medial view here, and you can see where this in blue is all ACA. PCA is going to cover this posterior aspect, which makes sense. And so if we look here at the homunculus, if we break this down by section, so this is going to be more so ACA, and then this territory here is going to be more so MCA. And so in the medial aspect here, a stroke affecting the anterior cerebral artery is going to more so cause leg weakness, versus an MCA stroke is going to more so affect upper extremity weakness. And you could also see that facial drooping that you hear about as well. And so that those, from a motor and a sensory aspect, these are really important to keep straight. So ACA is more lower extremity, MCA is more upper extremity, and facial droop. And it all comes back to these distributions. So we're not going to go through the tracks in too much detail here, but just to point it out. So if you have it's just to show that if this is the right side, this is the left side. So this is where those precentral gyrus, this is the corona radiata, where these corticospinal tracts are starting to form, and they come in here, and then they cross over here, and then they come down in the spinal cord and go to the opposite. So if you have a stroke in the left side of the brain, you're going to have symptoms on the right side as far as motor and sensory go. Again, if you have a stroke on the right side of the brain, it's going to more come down and affect the left side. Same thing with sensation. So we'll point this out briefly right here. So this is why it's important to know if someone is right hand dominant or is right or left hand dominant. Because if they're right-hand dominant, most people who are it's about 80% who are right-hand dominant their left hemisphere is the dominant hemisphere. And so the dominant hemisphere contains these two speech centers, Wernicke's area and Broca's area. And so Wernicke's area, if you have a stroke affecting this region, this would lead to receptive aphasia. So Wernicke's. So receptive aphasia means that they can speak fluently, but they can't process or understand written or spoken language. And so even though they can speak fluently, the sentences are fluent, they usually don't make much sense because they just can't process spoken or written language. Versus Broca's area is more for expressing, and so that's what's called expressive aphasia. And so expressive aphasia is where they can understand written and spoken language, but when they speak, it's very broken language. It's very, it's not fluent, it's not smooth, and so it can also be hard to understand as well. You can kind of make out what they're saying, but it's not extremely clear. So this is more a problem of actually expressing communication versus actually understanding communication. And this is because of where this is in this more lateral aspect, this can be affected in an MCA stroke. And then out here, this can be more so, it depends where the MCA stroke is, but it could be MCA or PCA. So we have a case here. This is a new case. This is not a previous DaVinci cases. It's similar to one of them, but it is definitely a new one here for you. And it's, again, just to help tie together everything, the concepts we went through. So let's go through. So when you go through a case like this, if it's on an exam or if you're just going through the DaVinci cases, what you want to do is you want to understand what each sentence means, what it's telling you about, because in most tests, every sentence is put there for a reason. And so you want to know what that reason is to help put together the picture. So you have a 48-year-old right-handed man presents to the emergency department. So again, right-handed, so he's probably going to be left hemisphere dominant. Is going to present to the emergency department with weakness and numbness of the right lower extremity. So he's a younger guy, so usually strokes happen in older patients. So the fact that he's a younger guy, this makes you somewhat concerned here. So past medical history is notable for hypertension, definitely a risk factor for stroke, and atrial fibrillation, which is also. So let's see if he's on blood thinners. So he was previously prescribed amiodarone and warfarin. So the amiodarone would be to control his heart rhythm, his atrial fibrillation, and then the warfarin would be because, again, you can form clots in the left atrium because when the heart isn't pumping efficiently, you have stasis of blood flow. And so when you have blood flow that's kind of sitting around, that's when clot formation can happen. And so then you can start throwing clots. And so if you're not taking a blood thinner like warfarin, you can build up clots and you can build up clots and send them off into the peripheral circulation, such as the cerebral. So this is important that he's prescribed warfarin. That's exactly what they're given. So however, he is non-compliant with his medications. So this means he's not taking his amiodarone or his warfarin. So while he would be decreased risk for stroke if he was actually taking his warfarin, he's not. And so you need to just assume he's not. And so he's at significant risk for embolism. So on physical exam, he's found to have 4+5 strength in his right upper extremity. So he's got a little bit of weakness in his right upper extremity, but much more weakness in his right lower extremity. And then he has 5 out of 5 strength in the left upper and lower extremities. So the left side's okay. And then he's got decreased sensation to light touch in the right lower extremity. So he's got some weakness there as well. A head CT reveals no intracranial hemorrhage. So again, remember, this is really important. You want to make sure it's not an ischemic or hemorrhagic stroke. And so you want to pay attention to that. I just saw the question on conductive. So I just saw your question on conductive aphasia. Just give me a second to finish the case out, and I'll talk about that. I'll go back to that slide and talk about it in a second. Thanks for your question. So which of the following is the most likely to undergo the cause of this patient's condition? And so what we're looking for is which of the following is going to most likely cause a right lower extremity weakness and numbness. And so this one, if you see, he's a younger patient. He doesn't have a history of like hyperlipidemia. He doesn't have a history of heart disease. And so atherosclerosis, this would again just be formation of a plaque. These seem a little less likely. What seems like he's definitely at risk for an embolism. So it seems like it's going to be one of these three choices. So if you look at the breakdown, remember anterior cerebral artery is definitely lower extremity weakness versus middle is upper extremity weakness. And then posterior cerebral artery is more so vision because that's the occipital lobe. So he's not complaining of vision problems. He's got a little bit of weakness in the upper extremity, but it's more so the lower extremity. So it would be embolism. So the answer would be embolism to left anterior cerebral artery. So the question is about, throw some light on conductive aphasia. So conductive aphasia, it's a rarer form of aphasia, and what it's really is they're able to understand and they're able to understand information, both written and spoken. They're able to speak, so it's not like Broca's where it's broken or anything, but they're not able, if you ask them to repeat something, then they're not able to repeat it properly. So they can speak something once, but then they're not able to, process it and repeat it again to you. And this one is this is a result of usually damage to the parietal lobe of the brain, mainly again in the dominant hemisphere. So if it's a right-handed individual, it's going to be the left hemisphere. So I hope that answered your question. We can, if you want, I can do a more detailed video about aphasia, maybe even do a DaVinci cases down the road about it too as well. So that's a good question. Aphasia is kind of a complex thing. So thank you for your question. So let's talk about some visual field first the visual pathway and then visual field deficits. So this is something that comes up a lot on exams, and you definitely want to know these pathways, and they can be a little tricky. So let's just walk through this. So this is the left eye, this is the right eye, and so each eye is then divided into quadrants, as you can see here. So you have the superior quadrant and the inferior quadrant, and this is on both sides, and you have the left and right. And you want to think of it as left and right within each eye. So this is left, this is right, and so you have the superior and inferior quadrants here, and then the superior and inferior quadrants here on the left and right side. And so what we'll go through here is, so this would be the left visual field, this is the right. So usually, I know like in radiology, you're usually looking at it where this side is right and this side is left, but just kind of flip that for a second here while we go through this. So this is left and this is right. And so if we start here, there's a lot of crisscrossing that goes. So I'll try to go through this slowly so you guys can follow me here and keep track of these. So if we go through with the right eye here, with this red, the inner portion here, this inner portion here is getting received by this outer portion of the retina. So you go in to out, and then this outer portion of this visual field is getting received by this inner portion of the retina. Same thing over here. So you have the inner field here, which would correspond to the right side of the field of the left eye here, is getting received out here by this outer portion of the retina, or the temporal retina. This is the inside's called the nasal retina. And so the nasal retina would receive this outer field input like this. And so then the fibers come together and they travel in the optic nerve once they leave the retina. And then they come here to the optic chiasm. Now what's important that happens at the optic chiasm, as you can see, is these fibers coming from the temporal retina on either side, they actually crisscross, or they cross over. And so you can see excuse me, not the temporal retina, the nasal retina. So the nasal retina, the fibers coming from the nasal retina, they come here and they cross over. So you can see in blue here where this is receiving these outer fields, it's coming in like this, and it crosses over like this over to the other side with the other blue fibers here. So this red on this side, the red which is taking from the left here, this left outer field, is coming down here and crosses over to this side, this hemisphere as well. So you have crossing over of the inputs from these outer fields. Once you leave the optic chiasm, then you're within it's not labeled in the diagram, but it's called the optic tract. So then you're in the optic tract, and then you synapse in the lateral geniculate nucleus here. And then after you synapse, you split into, and we have a nice diagram that shows this better than me just drawing it like this, but here you have the optic radiations, which carry inputs from these inferior quadrants, and then you have the Meyer's loop, which carries inputs from the superior quadrants. And so that Meyer's loop travels in the temporal lobe, and the optic radiations travel in the parietal lobe, and then they synapse here in the occipital lobe at the primary visual cortex. So let's go through each of these deficits. You've probably seen diagrams like this before in your textbooks or in your lectures, but let's just go through each of these. So over here I have all of these vision deficits, and we're going to mark on the diagram here where these occur, and I'll explain why. So very first here, if you were to impinge on the optic nerve, you're going to have what's called monocular visual loss. And so you're going to have all four quadrants of that one eye are going to be gone. Complete full vision in the left eye here. So that's pretty easy there. So the next one is if you were to have a lesion impinging on the optic chiasm. A very common example of that is a sorry about that. Apologize about that. For some reason, my computer went haywire there. So anyways, I was saying, so optic chiasm lesions. So a very common example of an optic chiasm lesion is a pituitary tumor, which grows large enough to compress. The other thing that can compress the optic chiasm is a cerebral aneurysm at the anterior communicating artery. So that if it gets large enough, that can also compress the optic chiasm. And so that's what causes a visual deficit called bitemporal hemianopia. And so bitemporal hemianopia, you interrupt the crossing over of these fibers from the nasal retina. So you have these outer fields coming in like this, and you can see where the blue would come in here, and so you're disrupting that crossing over from this side and then this side as well. And so that's what gives you this, where you have your outer visual fields are impacted like this. This is also known as tunnel vision, because again, it's kind of like you're only seeing what's immediately in front of you versus peripherally. So then we get into where we impact the optic tract. And so the optic tract will give you a contralateral anomalous hemianopsia. So this is the right side, right? This is the left. So the right side is going to give you a left-sided anomalous hemianopia. So if you look over here, this is the left half of the left eye. This is the right half. This is the left half of the right eye. The right half of the right eye. And so what's going to happen is you're having inputs come from both these left sides traveling here, because here you had the nasal retina in red here, which is receiving these outer field, and this outer field corresponds to the left side here of the left eye. So that's traveling here with the red, and then we just follow the red here. This is taking on the right eye. This is taking from inputs from the left side, or the left visual field for the right eye. So you can see left, and then left as well. And so then these come together to form the right optic tract on the right side here. So if you impact the right optic tract, you're gonna lose vision in both of these left side here. And so that what gives you this lesion here, which is a left anomalous hemianopia. Now, what can potentially cause this is, obviously, a direct impact to it. The other thing is an MCA. If you remember our territory of distribution, this is our MCA stroke distribution. So an MCA stroke can actually potentially cause, not always, but potentially can cause a anomalous hemianopia. If the lesion were on the right side here, it would just be, if the lesion were on the left side here, it would be a right-sided anomalous hemianopia. So it's the opposite side. All right, so now I've taken this portion right here and blown it up over here to give you a better look at this. So this is the lateral geniculate nucleus. This is the primary visual cortex. And so what you have here is you have optic radiations, which are in the blue here. And these are traveling in the parietal lobe. And then Meyer's loop, which is traveling in the temporal lobe. And they travel at a 90, you want to think of this as a 90-degree angle. They're orthogonal to each other. And so the parietal lobe, the optic radiations, they carry inputs from these inferior quadrants. And so if you're on the right side here, this is going to be from the left, it's going to be the contralateral side. So the right optic radiations are carrying inputs from the left inferior quadrant. So this is the left inferior quadrant of the left eye, and this is the left inferior quadrant of the right eye. Meyer's loop carries inputs from the contralateral superior quadrants. So the Meyer's loop of the right temporal lobe here is going to carry inputs from the left superior quadrant of the left eye and the left superior quadrant of the right eye. And then on the left side of the brain, it's the opposite. The left optic radiations are going to carry inputs from the right inferior quadrant of the left and right eye, and then Meyer's loop on the left hemisphere is going to carry inputs from the right superior quadrant of the left and right eye. So if we look at here, superior quadrantanopia, so given that if you have a lesion here impacting Meyer's loop, it's going to cause a contralateral superior quadrantanopia, because Meyer's loop is carrying inputs from these quadrants right here, the left superior quadrants. So you're going to lose vision here and here. This is what's called, you may hear pie in the sky. And that's because in the upper portion or superior portion of the visual field, you have loss of vision. And so Sometimes you may hear that referred to as a pie in the sky. If this were a lesion on the left Myers loop, it would be a right superior quadrantenopia. So just remember, it's the contralateral side. And so then here, if you have a lesion lastly here in the optic radiations, this is the last one, then we'll get into the case. You have a left inferior quadrantenopia. And so again, this is because the right optic radiations are carrying inputs from these left inferior quadrants here, from both the left and right eye. So you have a left inferior quadrantenopia. And so since that travels in the parietal lobe, that could be, if you had a tumor in the parietal lobe, or if you had some kind of lesion in the parietal lobe, that can result in that. All right, so we've got a nice case for you here. This is a so again, with the case, you want to you want to look at each sentence and what each sentence is telling you. So you have a 67-year-old right-handed woman, so she's again left hemisphere. I apologize about my handwriting. That's a 67-year-old right-handed woman. It presents to the emergency department with weakness of her left upper extremity and drooping of the left side of her face. So we're definitely suspicious for a stroke here. It's an elderly woman. And this is a nice case because it's going to kind of tie together everything we've talked about so far. Past medical history is notable for hypertension, hyperlipidemia, diabetes type 2. So definitely risk factors for stroke as well. She takes propranolol, which is likely for her hypertension. Torvastatin, which would be, for her lowering her cholesterol, her hyperlipidemia, and then metformin for her diabetes. Doesn't say anything about her not. In questions like this, unless like the last question where it says the patient doesn't take it, you should just assume they take it. And tests are not like real life. It's usually pretty clear and cut. It's because there's not meant to be any ambiguities. So on physical exam, she's found to have 3 out of 5 strength in her left upper extremity, 4 out of 5 in her left lower extremity, and then 5 out of 5 on the right upper and lower extremities. So she's much weaker. So her upper extremity is much weaker than her lower extremity. So much weaker than lower extremity. She has decreased sensation to light touch in the left upper and lower extremities. So again, she's got weakness, or she's got weakness on the left side, and then she's got numbness on the left side. Again, kind of pointing towards a stroke. So head CT reveals no intracranial hemorrhage. So again, we know this is more so an ischemic stroke than a hemorrhagic stroke. And so I think someone's thrown in a guess at the question here. I think we'll see. We'll go through some things here, and then we'll see if you're right, my friend. So the question is, which of the following visual effects could present with this? So based on this, she's got facial droop, weakness in the upper extremity. So this is an MCA. So what you want to boil down is, what's the question really asking? So the question's asking you is what visual defect could present with an MCA stroke. So let's go back to our diagram here. We look at our MCA distribution here, and here. So that's going to correspond to here and here. And if you remember, we talked about that optic tract is affected. So what you want to look at is what an optic tract. So let's go through each of these. This is not the answer, because this would be optic nerve. This is bitemporal hemianopsia, which is that compression of the optic chiasm. C would be that left homogeneous hemianopia, which would correspond to the optic tract. So that's looking like a winner. So it looks like you may be right, my friend. And then this would be a left superior quadrantenopia, and this would correspond to Myers loop. And so that's definitely not the answer. And this would be an inferior left inferior quadrantenopia. So this would be optic radiations. And so again, it doesn't seem like it's a parietal lobe. And so you could see these on exams where they show this, where they can either write out the actual lesion, either bitemporal hemianopsia or homogeneous hemianopia, or they could do it like this. Either way, so you want to be ready for that. So you guys are right. It's an MCA stroke with a left or a right. It is a left henominous hemianopia. Excuse me. So let's talk a little bit about neurotrauma here. Neurotrauma, again, is a kind of a broad field, but what we want to go through is really these are two that you're going to see a lot on exams are epidermal hematoma. Also, if you do rotations or work in the ER, you're definitely going to see this. If you work with neurosurgeons or neurologists, you're going to see this as well, and on the trauma service in general. So epidural hematoma is a fracture of the pterion of the temporal bone. So the pterion is a structure where the frontal, parietal, temporal, and sphenoid bones come together. And so it's kind of a weak point there because it's a junction between all these bones. And so if you break that, it can lead to laceration of the middle meningeal artery, which is a branch of the maxillary artery, and remember travels through foramen spinosum, which that can be asked, especially on like head and neck anatomy questions. And this results in bleeding between the dura and the skull. So this is really important, between the dura and the skull. So if you remember, so if you have the skull here, and you have the dura here, this is where epidural is going to be, above the dura. And then down here, you're going to have arachnoid, and this is where subdural bleeds are going to be. So subdurals are from breaking of bridging veins from the brain parenchyma. I'll draw that out in a second to kind of make sense of that, to the superior sagittal sinus, and this results in bleeding between the dura mater and the arachnoid mater. So that's going to be in here. So let's go to the whiteboard here for a second just to show you what these bridging veins. So again, apologize about the crude drawing. So this would be your cerebral hemispheres like this. This would be, we'll say this is your right side, this is your left side. And then here, this is your skull like this. And then this is your superior. This would be a coronal view. Superior sagittal sinus. So what you have are these bridging veins that drain the brain parenchyma into the superior sagittal sinus. And what happens is, if for a subdural hematoma, is these get torn or broken. And so what a lot of times what risk factors are is if the brain atrophies, and so if you increase the distance that these veins have to travel. So if the brain atrophies, so like with dementia or old age, even just the brain atrophies with old age, you're going to increase this distance between the brain and the superior sagittal sinus. That causes increased tension on these veins. It makes them more taut, and so it makes them more at risk for breaking. So in a individual in their 20s who's otherwise healthy, they're going to be much less risk than like an 80-year-old with dementia, because their brain's going to be much more atrophied, and this is going to be much more resistance on these veins themselves, so much more at risk. The other thing is alcoholism can cause brain atrophy as well, and so tearing of those veins. So I just wanted to show you that real quick because I couldn't find a good diagram about that. Hopefully that helped clear things up. So kind of the big difference. So big difference is an epidural hematoma is an arterial bleed. So it's going to be high arterial, higher pressure. It's going to bleed faster, versus a subdural hematoma is a venous bleed. So it's not going to bleed as fast. It doesn't mean it's not important. Doesn't mean it couldn't kill you. So it's just that epidural hematoma is going to, I guess, bleed faster and build up faster. So what's scary about these is they initially present with a lucid period. So someone could appear normal. They could be talking, walking around. And then what's really sad with these is you'll hear these stories and then, a day later, oh, they drop dead. And so as the bleeding continues and blood accumulates, that can compress the brain, and then they cause headache, ocular motor nerve palsy if you're compressing the cranial nerve 3, weakness of the contralateral extremities if it builds up enough and compresses the brain. And then you can have also contralateral vision loss if you cause compression of the posterior cerebral artery. Subdural hematoma, patients are going to present with signs of increased intracranial pressure, such as like headache, vomiting, papilledema. They can also present with loss of consciousness, weakness, ataxia, vision changes. It just depends on what's getting compressed. I'm so sorry about why this keeps doing this. I don't know why. Okay. Why is this doing this? Okay. Again, I apologize about that. Sorry. Okay, so people at risk, very young, and then the elderly. And so the very young, what you hear about is shaken baby syndrome, because in the very young, again, that brain hasn't fully developed. So that distance between the brain and the superior sagittal sinus for those bridging veins is much larger. So again, they're at risk. Plus, they're just weaker. And so infants, very much, especially with shaken baby syndrome, which would be a form of child abuse, and then obviously the elderly. Other risk factors are anticoagulants, so if they're on warfarin or something like that, alcohol abuse, because that causes brain atrophy, and then dementia, and then also Alzheimer's would fit into that as well. So imaging, this is definitely something you could see on an exam. So you'll see on imaging here, they can have this epidural hematoma, has this convex shape to it. And what's important is the reason it forms this shape is so if we draw the skull like this, the dura tightly adheres. Now, in reality, the dura is much more up against the skull, but this is just to show you this for demonstration purposes. So the dura adheres to the undersurface of the skull bone at cranial sutures. Remember, those are those points where during development the skull bones would fuse together, and so those cranial sutures are where the dura is anchored. And so the dura gets anchored here, and so if you have blood building up in here in the epidural space, it can only go so far. It's going to end up stopping at these dural sutures, and so it's going to build up and build up and build up like this. And so that's what you see. So this is probably a cranial suture here, and this is probably a cranial suture here as well. So blood from epidural hematoma cannot travel past areas where the dura is firmly attached to the skull, and so it does not cranial sutures and combine to the area adjacent to the trauma. Versus a subdural hematoma is more crescent shaped like this, as you can see on this is an axial CT. And so this is because you're beneath those. So in an epidural or in a subdural, so here again, here's those cranial sutures. Here's the dura like this. In a subdural, the blood's building up below these dura, so these sutures don't matter for a subdural hematoma. So it can spread all throughout the subdural space here. And so really the big thing on imaging is it involves a larger portion of the cerebral hemisphere, and it's not contained by those dural sutures adhering to the skull. So if we just look at these for comparison, again, this is where it's more convex shaped like this, and then it's more widespread like this. So let's get to a nice case here. A 65-year-old man presents to the ER, so it's an elderly guy, after falling off his ladder. So he had a fall at home, and he hit his head. He hit the left side of his head hard on the pavement and has pain. So remember, the left side is where your temporal bone is. So it could be a temporal bone fracture, but we don't know that yet. We even say it here, especially in the temporal region. He is conscious, so he hasn't lost consciousness, and he appears alert and aware. Remember, though, don't be thrown off by that, because epidural hematomas can potentially present with, where someone's alert and aware. Vitals: heart rate 70 beats per minute, so that's pretty much normal. Blood pressure is a little low at 100/70, but it's not like he's going into shock or anything like that. He's breathing kind of fast, but that's not surprising. He could just be anxious. No neurological deficits are found. However, he has a history of hypertension, type 2 diabetes, smoking, alcohol abuse, and sedentary lifestyle. So he's not a very healthy person. He's got a lot of risk factors for cardiovascular disease, stroke, but these are key here. So you got alcohol abuse, and the fact that he's an older guy. Those are two risks for brain atrophy, which would be for a subdural. So we got signs here potentially of an epidural or a subdural. So you have a head CT is obtained and shown below. Which of the following is on the underlying pathology? So we want to go through. So it's kind of a secondary question. It's asking you which of the following would cause. First, you got to determine, is this an epidural or a subdural hematoma, and then you got to go through what would cause that. So if we look at the imaging here, it's crescent shaped like this. It's spread all across the hemisphere. So I know he hit the left side of his head. That doesn't necessarily mean that he fractured his pterion and gave him an epidural. So you just got to go by the imaging here. The imaging here shows that this is a subdural hematoma, or an SDH, and that's just by the imaging. Because remember, with an epidural, it's confined to those dural sutures, and so it's going to give you more of that convex shape like this. So it's a subdural. So it's asking which of the following is the underlying cause of a subdural hematoma. So fracture of a pterion, it's not that because that's an epidural. Burst of cerebral aneurysm at the anterior communicating artery. Well, we know it's not. This is not typical present. This is more, again, you just got to go by the imaging. It's a subdural hematoma. It's not imaging you would see for a subarachnoid hemorrhage. That's what this would cause. Burst of cerebral aneurysm, again, that would cause subarachnoid hemorrhage. Breaking of bridging veins, so that's subdural, and then infarction of the left transverse sinus. So again, this was kind of thrown in there to throw you off. Again, you just got to go by the history and then the presentation. Infarction of the left transverse sinus. It's not going to show up like this. It's not going to be some big dramatic crescent-shaped thing like this. This is more like a blockage within that. You'd more see, if anything, is you'd see where at a point distal to that or proximal to that, you would see enlarging of the vein because it's obstructing blood. You could potentially see that on imaging, but even this imaging of this is kind of beyond medical school level. This is more on the even end of med school or the resident level even. So it wouldn't be that. So it'd be and again, subdurals are caused by breaking of bridging veins. So that's our answer choice. So lastly here, we'll finish this session up. I know we're getting close to the hour here. We'll just talk about different types of hydrocephalus, and then we'll close this out. So accumulation of hydrocephalus is accumulation of cerebrospinal fluid or CSF within the brain. Two main types are communicating and non-communicating. So let's first review here the flow of CSF. So it's made here in the choroid plexus, which is found in the ventricles here. Then it travels through this interventricular foramen. And remember, if you look at a coronal, you have two ventricles like this. And so they're each draining through their own, each of them have their own interventricular foramen, or the foramen of Monroe, then goes into the third ventricle here, which is shown here. Then the third ventricle kind of travels through the CSF, and then travels through this pipeline known as the cerebral aqueduct and goes into the fourth ventricle here, which is found anterior to the cerebellum and adjacent to the brainstem. And then from the fourth ventricle, then it goes into the subarachnoid space, where it goes around and bathes the brain and spinal cord. Now, what's important for hydrocephalus is you have these arachnoid granulations where CSF eventually drains into these protrusions of the subarachnoid space into the superior sagittal sinus. So it's draining out here. So communicating versus non-communicating, you could definitely be asked about this. We actually have a DaVinci cases that covers this. It's I believe it was the one from last week, I think. Yeah, I think it was from last week. So communicating hydrocephalus, this is impaired CSF reabsorption at the arachnoid granulations within the superior sagittal sinus. So this is where you have blockage of drainage. So this is a drainage problem. It's not this is not an obstruction anywhere. That would be a non-communicating, which we'll talk about on the next slide. So communicating is where you have impaired drainage here. And then you can see these here, these arachnoid granulations here, where they kind of jut out here. And you have impaired drainage into the superior sagittal sinus. You could also have excessive CSF production as a result of this. This is a non-obstructive. Again, this is not due to some tumor or some lesion compressing and obstructing flow. So you have normal CSF flow throughout. It's just a drainage problem. Multiple causes. You can have a congenital malformation of the arachnoid granulations, and then you can also have a scarring of the arachnoid granulations from infection, so like meningitis, inflammatory, or hemorrhage. So a subarachnoid hemorrhage that's from a bursting aneurysm can cause a communicating hydrocephalus. And then you have normal pressure hydrocephalus. So this is a type of communicating hydrocephalus, and this presents with that triad. And the reason it's normal pressure is the ICP is normal. So it presents with a triad of dementia, ataxia, and urinary incontinence. It's just typically seen in elderly patients, and this is that pneumonic, wet, wacky, and wobbly. Then you have non-communicating hydrocephalus. So to contrast it, this is caused by obstruction to CSF flow at any point along the cerebral ventricular system. So you could have, something blocking it here at the foramen of Monroe. You can have cerebral aqueduct stenosis, which if we show
let's see, here was a good here we go. Here's a good picture right here. So you have cerebral aqueduct. It could be stenosis. That's a congenital malformation, where you can see that as well. You could have a tumor here, very common, like medulloblastoma in the cerebellum, that compresses in on the fourth ventricle, and that causes obstructive hydrocephalus. So really, there's a number of things, as we say here: congenital malformations, tumor, and then hemorrhage. We'll throw this in here: Hydrocephalus Ex Vacuo. So this is technically not a communicating or a non-communicating hydrocephalus. It's actually a separate pathology in and of itself, and what it is enlargement of the ventricles secondary to loss of brain parenchyma. So what causes are brain atrophy, like dementia, Alzheimer's, brain injury, and then some psychiatric disorders such as schizophrenia. So the big thing here is, so this is an axial T2 weighted MRI. You know it's T2 because on T2 CSF lights up, and you can see that here. And so what's important to note here is that this is a compensatory reaction. So what you had is kind of atrophied away of brain tissue, and then really the way you just think of it is these expand out to fill that space. So there's space left by this atrophy of brain tissue, and then the ventricles and other CSF structures, they just kind of naturally expand. It's kind of just a natural reaction. It does not cause an increase in CSF pressure or ICP. All right, so thank you guys. That closes out our session. I'm sorry we didn't get to a case for hydrocephalus, but we, like I said, the last DaVinci cases, if you want to go check that video out, it's in our channel. You can check out that case just to get another review of, or a tryout of hydrocephalus. So definitely subscribe to our YouTube channel if you haven't already. We appreciate it if you have. You can hit the subscribe button below. We put a new video out for DaVinci cases every week, every Wednesday. We're putting a new one up later today, so definitely pay attention for that. Check out our anatomy and biochemistry books and video courses on our website, both on our website. You can check out the books as well on Amazon. The links are in the description. We're trying to do these group sessions maybe about once a month, maybe twice a month, just kind of depending on people's interest. Hopefully you guys like this. Definitely send me feedback on this. Like if you follow me on Instagram, YouTube, Facebook, anything like that, send me a direct message to what you thought of the session, if you thought it was good, if you didn't like it, if there was topics you would have liked to have seen covered more, please give me your feedback. I really appreciate it. And so definitely let us know your feedback. If you want more individual tutoring, definitely I can tutor you on an individual basis. I've been a tutor now for medical school content for 5 years, and then even beyond that for other scientific content. So I've tutored medical students at all levels for pathology, physiology, anatomy, neuroanatomy. So email us at support@dvi, excuse me, I apologize, support@dviacademy.com. dviacademy.com. I can add that to the description below. I apologize about that. So it's the same as here, support@DVI Academy. And then follow us on social media. I know a lot of you guys already do. Really appreciate that. Really appreciate the love you guys give us on social media. But if you're not following us, definitely we're on all the major platforms. We're on Instagram, we're on Twitter, we're on Facebook. We're also on TikTok too. We have some cool videos on there if you want to check us out on there. So definitely and then check out our website too. All right, guys, thanks a lot. Really appreciate it. I hope you liked the session, and definitely send me your feedback. I really want to know, because again, this is for you guys. I want to know that this was really helpful for you guys. All right, thanks.